Awesome. Thanks, Ash. Thanks, supporters. Phil, you got any shout outs today? Shout outs?
Well, I know my students are supposed to be on for bonus points, so hopefully they're there.
Bribery.
Yeah.
Yeah, you know how hard it is to get students to do things that don't
Shout
count
out.
for a grade.
Shout out to my students. I didn't give them extra credit though.
Well,
I just
we'll
told
see
them to
who
get
has
on.
more.
It'll probably be you because you're giving credit.
I'm not.
Very
If you're
true.
giving credit, you're getting more students than me
Wait,
for
we
sure.
have 133 participants in November. That's pretty good.
That's pretty good.
That's
Pretty
pretty
good for
good.
number what, Phil?
30.
31.
31.
Mhm.
You're close.
Oh.
You're very close. Paul, this
31.
is the 31st journal club. We've done it like
Hmm.
two years and 6 months.
Wow.
Barb, do you want to introduce yourself real quick?
Sure. Hi, everybody. I'm Barb Hoogenboom. I hail from Grand Rapids, Michigan. I am the editor-in-chief of IJSPT and just thrilled to be here with this crew. We're going to learn something new tonight.
Thank you, Barb. Philly?
Everybody, Phil Page from Baton Rouge, Louisiana, Fran Yu, DPT professor there. Thank you to the journal, to our sponsors, especially to Ashley, and of course to Dr. Cleland. Thanks for being here.
Thanks, Phil. I'm Rob Manske from Wichita State University. We're glad everyone jumped on. We got a great night tonight. We've got one of my favorite physicians from town here, Paul Cleland. Let me tell you just a little bit about Paul. He's a primary care sports medicine physician from Ascension Via Christi. I work at Ascension Via Christi as well. He chose his career path because he loves seeing people get better, loves treating patients. He says that the trust patients place in his care is a privilege he truly values and respects. Sports medicine allows him to treat patients of all ages, activity levels, and he loves helping people get back to doing what they love to do. So, Paul, thanks for joining. Paul, I have to tell you all, Paul and his partner Drew are really they truly are two of my favorite doctors. If my family sees either one of them, I see them when I have problems. If I have anybody that doesn't want to have surgery, I always send them to either Paul and his partner. So, Paul, I can't thank you enough for joining us tonight.
Yeah, it's my pleasure, Rob. Thanks for the introduction.
Is there anything go ahead. Sorry, I was going to ask if there's anything I missed on the introduction about you.
No. It's a two-way street, though. I got my shoulder scoped a few years ago, and I had Rob do my PT, and then I found out how much it costs for each visit, and I said, Rob, I'm done with you, man.
I don't set the prices. I don't set the prices.
I know it. We don't. Yeah. Yeah. So, a little bit about myself. So I'm in Wichita with Rob, and I am one of two faculty at a sports medicine fellowship, a primary care sports fellowship. And so we train a few fellows every year, usually family medicine trained, but sometimes they come from PM&R or PEDS or some other background like that. And I'm also one of the team physicians at Wichita State University, so we get to see a lot of athletes around Wichita too. And the genesis of this, I thought I should kind of introduce that I'm one of the faculty at the fellowship because that's kind of how this started for me. So we always have our fellows rotate with the orthopedic surgeons, and one of the orthopedic surgeons who we share a lot of patients with, he had seen a patient, I think back in about February or so, and it was an adhesive capsulitis, and he'd gotten frustrated with the fact that they weren't really getting better. And one of our fellows was kind of bugging him. He's like, well, have you ever tried any hydrodilation? And he was like, no. And I don't know that I'm really going to have a lot of faith in that, but I'm kind of fed up with this. So go ahead, have your hand at him and see what happens. And I had been wanting to try this on a patient for quite a while, but hadn't really run into one that trusted me to do it. And so we got the bite from this ortho, sent us this patient. We decided to do it, and they were okay with it. And we did it and had really good success. And so the orthopedic surgeon said, all right, let's do this again. And so we did it again. We had really good success. And he said, all right, I'm sending everybody to you. And so we've worked a lot with Rob. Rob was kind of our he was our pilot with helping us do this, and wouldn't have been able to even start doing it without him. So I want to definitely give some props to him for this. But that's kind of how it all started. And I by no means invented anything of what I'm doing. I really stole it all from another primary care sports med doc, and I read quite a bit about it before, the idea of it, and have just kind of gleaned a lot from what several people have done, and somewhat made it my own. But honestly, most of these ideas have come from somebody else that had a lot of success. So we started doing it, and we've kind of just rolled through with more success. So it's been fun.
That's part of the reason I wanted to get you involved with this today, Paul, because it's not like you've done, hundreds of thousands of these, and I know you're modest enough to say you're not an expert, and you may not be, because you haven't done that many of these, but you've done enough of them now. You're starting to get the hang of it, and I feel like you know what you're doing, and the large majority of the people that we see that you do this with do fairly well. So, and I know it's like Barb said, that she doesn't even know anyone that's doing it where she lives. So it's not like everybody around the country is doing it. So it may be really, or I felt like it was a really good, timely topic to have on the Journal Club. So. So, well, the way we'll do this, Paul, we'll just start talking about, we usually have at least two articles. Sometimes we don't even get through one. Sometimes when we get through two, and then we have to have Phil tell some jokes toward the end of the Journal Club, because we're running out of time. Most of the time, I think we run out of time, probably more often than we go short. But so let's start with our first article, and it is by, I think it's pronounced Poku, P-O-K-U. Efficacy of hydrodilation in frozen shoulder, a systematic review and meta-analysis, published just last year, 2023, in the British Medical Bulletin. So first of all, Paul, I know there's different ways to do this procedure. Not everybody does it exactly the same. Can you describe for us how you perform it, or maybe even before how you perform it, what type of frozen shoulder patient, are there certain phases they're in, or what are you looking at when you decide, okay, this is the perfect person to have the hydrodilation? And then second, what all do you put in yours when you do it, or explain the procedure to us, kind of detail, and what it is that you put in it, and maybe why you use those injectables.
Yeah. So how I kind of got started with this again was looking at what another sports medicine doc was doing, and he'd had a high volume of patients. And so I kind of, trusted what he was doing. Essentially, he said he'd done 300 or 400 of these things. His concoction that he used was working really well. And so I said, all right, well, that's how I'm going to start then, because nobody had seemed to match the volume of this guy. And his name's Cole Taylor. I'll give him a shout out. I've never met him before, but he seemed pretty versed in this field. So I put a lot of trust in that. So
where's he at, Paul? Where's he at?
I actually don't know. Okay. Yeah, but I see his name quite a bit. I know he's a real sharp guy just on the stuff that I read about him. So if anybody does know him, email me on the side, and I'd like to give him some props. But yeah, so anyways, how it starts, we'll get a lot of our patients from the orthopedic surgeon. We actually don't see as many in our clinic. They usually come from the orthopedic surgeon. And they come with a range of motion deficit and pain, as you'd expect. Some of them are pretty acute. We'll see them maybe within about I would say 6-week, maybe 4-week onset at the very earliest. A lot of them have been dealing with it for several months, and some of them even for a few years. And so what I really look for is the range of motion deficit. Not everybody comes with that. And with those patients, I actually may consider just doing a steroid injection with them. But as long as they have a decent range of motion deficit in one of 3 planes, then I'll consider doing it. How we do it, I actually do a combination of a suprascapular nerve block as well as a hydrodilation. And that's based on some studies that show that people seem to do better with the suprascapular nerve block just by itself. So combining them seems to hopefully give them better anesthesia for the manipulation afterwards. So the idea behind this whole procedure is We like to get them numb and numb enough to where they can go get manipulated by you guys, get their range of motion back, and hopefully kind of start reversing the process of this. So if we can't get them numb enough to where they can get manipulated well, then I feel like we've lost some of the efficacy of this procedure. So the way we'll start is we'll locate the points of entry with the shoulder with an ultrasound. We do all ours ultrasound guided. We'll look for the suprascapular nerve at the spinal glenoid notch, and then we'll look for the glenohumeral joint. And we'll mark that spot. We'll get them numb at the spinal glenoid notch. Usually we use about 5 cc's of lidocaine for that nerve block. Ironically enough, I've had more patients come in and they say they have their PT visit scheduled maybe further after the appointment than I would like. And
Because you want it literally right after.
yep.
I mean, or as
So
soon as
go ahead, Rob. Yeah.
soon as you can. I mean, as soon as they can get to our place.
Yeah. Yeah. So the way that Dr. Taylor had his patients kind of designed to do this was within at the maximum 2 hours, usually 1 to 2 hours after. That way the lidocaine is still effective. And I've had a slew of patients recently that have come in and said, well, my PT appointment's not for 3 or 3.5 hours. And so in those patients, I'll add maybe a little different anesthetic, one that's longer acting. And they seem to have done okay, but it's not necessarily ideal. So we'll block the suprascapular nerve, and then immediately after that, we will enter the glenohumeral joint, and we'll put in a combination of anesthetic, steroid, and sterile saline. My combination, and this is the one from Dr. Taylor, is 51 cc's. It's 10 cc's of lidocaine, 1%, 10 cc's of ropivacaine, 0.5%, 1 cc of steroid. And so that's 21, and that's all in one syringe. Once that is injected, then we'll do the saline syringes, and it's 3 10 cc syringes in a row, and then we'll be done. And so we're looking for several things when we do this. You know, we're using a pretty large gauge needle so that we're able to push the fluid fairly fast. And we're making sure that the fluid goes in the glenohumeral joint, and we'll see that expansion of the capsule. While we're doing it, we have to make sure, obviously, that it's in the joint, not outside of the joint, or there can be some issues. And then we're watching for a couple of things as we do it. Number one is to see, as we take off our initial syringe, we'll look to see if there's backflow. And that tells us that pressure within the joint is high. If there's no backflow, then we obviously don't have a ton of pressure. And so we're kind of learning from that. And then we'll watch as we're injecting, do we get a loss of backflow or a loss of pressure within the joint, either visualized on the ultrasound, or do we feel it and we see that, you know, initially when we were pushing the medicine in, we unscrew the syringe and it backflows real quick before we're able to get the next one on. Sometimes we'll see that all of a sudden as we're pushing, it's kind of harder to push, and then boom, it pops. And all that pressure is gone. And when we unscrew it, there is no backflow anymore. So at that point, obviously, we've ruptured the capsule.
Does that happen a lot? I was going to ask you about that because that's one of the complications of this procedure. Does that happen a lot? Or have you had it happen?
Yeah, it's a good question. And we're starting to track it. I would say I only have anecdotal numbers. I would say it probably happens I'm 20 to 30% of the time. So it actually does happen a fair amount.
Yeah.
And some people, it will happen in the beginning. You know, it might happen 10 cc's in, and some people will happen maybe 20, 30, 40 cc's in. And I read quite a bit about this. You know, this will touch on some of what the first article, the meta-analysis, touched on, that a lot of people actually would inject enough fluid with the goal to rupture it.
Yeah, I remember reading that.
Yeah, and so they would keep going until they ruptured it. And the reason for that really is because of what the surgeons would do with the patients that failed everything. They would go and they would do a capsular release. And so the goal of this whole procedure was actually to get the capsule to rupture. You know, gleaning the information from Dr. Taylor and a few other physicians, this is not in the meta-analysis. They have said that in their experiences, they've noticed that the people that have early rupture tend not to do as well. The theory behind that is that they may not get the capsular expansion that they're looking for. And probably what happens is when they're injecting the fluid, the fluid finds maybe the weakest part of the capsule and pops out there. And
So it
so,
doesn't stretch it or doesn't dilate
Yep.
it or stretch it then.
yep. So they think the idea of the success behind this lies in the stretching of the capsule and those glenohumeral ligaments, the coracohumeral ligament as well. And when that thing ruptures early, it seems maybe not to lead to as much success. I don't think I've done enough of them to be able to really tease out whether or not they're having success or not. And for full disclosure, I think I've probably done 30 to 40. I bet I've done 40 of these now since I started in March. So decent numbers, but by no means do I feel like I'm an expert at this yet. So yeah.
So you get it, you inject it, you try to distend the joint, you numb it up, and then you want them to come to therapy.
Yep.
And therapy, how aggressive do you, I know the answer to this, but I'll let you, I think, answer. How aggressive do you want therapy to be? A lot of
Yeah.
times you can't, when you're seeing these patients, I guess you can be aggressive with it before you do this and there's no numbing agent, but the patients hate it, they're guarding, they're miserable, you're miserable because you're torturing
Yeah.
them. But you
Yeah.
actually want us to be relatively aggressive in stretching it to get their motion back, correct?
Yeah. Yes, you're completely right, Rob. And that's really the idea, is that they're numb enough to where you can really push them, stretch that capsule further, stretch those ligaments that are thickened and tightened further, and hopefully get that range of motion back. And so that's the idea. And I think where I see patients not do as well is when they have gone to a physical therapist who may not have any experience with this. They're not exactly comfortable with pushing them as much as they're able, because they might be getting a lot of resistance. So they may be afraid to kind of push through some of that. And I feel like those patients may not do as well. So yeah, our idea is basically, my phrase is go crank on them and get them moving. Yeah. And I tell the patient, you know what, when they start moving you, you might feel a pop, you might feel several pops, and that is okay. I do tell them that, yes, there is still a risk that we could injure you. We could tear a rotator cuff. There could be a dislocation, something like that. I have not seen any of that yet, but it is a possible complication. And if they have a crummy rotator cuff going into the procedure, that's something that I do think we should proceed with caution. But barring all that, get after it.
Yeah, and the majority of the patients that I've seen that have had this tolerate it. They tolerate it really well, and I think it's like you said, because it's numb. They don't really feel it. They say it feels tight, and it's a little uncomfortable, but nothing that's like. I mean, they're always amazed at how much more we can move it and how much they can tolerate it compared to if they're the people that we've seen before they have this procedure, when you can't get hardly any motion at all and they're guarding and it's horrible.
Yeah.
They're just shocked at how much more range of motion they have. And it's fairly standardly works that way, other than those several few that we've seen that have some problems that don't seem to get. Do you think it's because it's not getting they're not numb enough? Is that what you think? Maybe the reason they're still having pain, or like we talked the other day, maybe it's another problem, or maybe they have some comorbidity problems that are also interfering.
Yeah, I know it's really a tough call to decide why some of these people aren't getting better. And that leads me to a little bit of a dovetail, in that some patients I've noticed, as we're doing the injections, they have a lot of pain as the needle passes through the infraspinatus. And the infraspinatus can be really crunchy and thick. And so I've actually, in those patients where I've noticed that the needle is, as it enters that spot, if patients really jump at that and that area is not numb, I will save a little bit of lidocaine and try to push it in that spot, because I don't want any pain causing the therapist to be unable to move them like they're supposed to. So I feel like if that's all numb, then they hopefully will do better. That's something that I've kind of theorized might be holding some people back. So I've numbed up that spot a little bit.
Yeah.
Hey, I got a quick question for Rob and for Paul. So you get them seen within the first 2 hours, ideally. Then what's your frequency after that? And what if it's on a weekend?
We usually don't see them over the weekend. We give them a home program to do.
Okay.
And it really depends on how they do. I mean, we usually see them afterwards for as long as they'll come in. But no one is really, everyone that I've seen, I don't think they've come in for longer than about maybe 2 or 3 weeks max, and they're feeling good. It's
Awesome.
moving good, and they just self-select to not come in. You know, we have them scheduled out for 3 to 4 weeks, and most people haven't come back after about 2 weeks. I know I'm not the only person that's seen your patients, Paul. So is that the same with other people you're sending them to?
Yeah, pretty much. And I'll tell them too, there's some patients that like they can't afford physical therapy or for whatever reason, they may not be able to get there. And so I'll give them a handout that has detailed instructions about what to do for home exercises. And that involves a pulley. So I have them get a pulley off Amazon for about $10. And then I'll make sure they're doing pulley exercises 5 times a day. So it's quite frequent. But I'll tell them, you know what, if you can't get to physical therapy after the initial manipulation visit, I'm okay with it. I want you to make sure that you are diligent about your home stretching program with your pulley every day. And then I see them all back at a month because I tell them, hey, I'm doing this, but I'm in it, I'm in my infancy doing it. I want to learn from you. So I want to hear everything, your experiences from the first day, the first week, the rest of the 4 weeks. And I want you to tell me how you're doing because I'm going to change, my protocol based on what you're telling me. So all that to say, I think what Rob said, kind of the initial visit's the most important, and then maybe some more aggressive mobilization, the first few days after, first week or two after, and then see how patients are doing.
Well, we got some questions coming in. We have a question and answer, and Matt Stump has asked, how does hydrodilation affect the coracohumeral ligament, which appears to be one of the more significant limiters of motion? Does it affect the coracohumeral ligament?
Yeah, I mean, the idea is really to get it stretched out, the same as the other ligaments. And interestingly, some of the other sports med guys who have been doing this, I should say guys, people who are doing this across the country actually do a little bit of a needling procedure at that ligament, in addition to everything that we do. That's not something that I have started yet, but it's definitely got my interest. And not everybody's doing that, but I think at least 1 or 2 people are doing that. So I would say my short answer is basically to try to stretch it just like all the other ligaments and kind of keep it from getting adhesed and tight.
Okay, another shout out here. Guess who's on?
Is it my sister?
No, it's not. Well,
No.
No, I don't think so.
I wanted to give my sister a shout out too, because
you can
she
shout
was
out.
on
Give her
this
one.
email chain and she's like, hey, I see you're doing a little talk here in about a week. And I was like, oh my gosh, this is bigger than I thought. I really got to know my stuff.
Is she on
So,
tonight? Do you know if she's on?
I don't know. I can't
Well,
see.
shout out. Shout out
Is
for
her
her.
last name Corbett? I mean, what's her last name? Cleland or no? What's her last name?
Her name is Elena Newman.
Okay,
And
I'm
I don't know
looking.
if she's on tonight or not.
Shout out
but
Elena. Good for her.
She's
And Phil, guess who? Do you know who I'm talking about, Phil? Who's on every
Lori.
Lori Bogra.
Lori and George and Ed.
Yeah. George isn't asking you questions, but I know the general's on. He's in
Yeah.
the
I
he's
saw
in
the
back
general
listening.
too.
All right. Prohaska's on here.
Yeah.
Oh, boy.
Oh, no kidding.
Prohaska's on here.
Danny
Holy
one
cow.
time.
Shout out Prohaska. Okay, I got to get Lori's question first. How lasting is the range of motion with continued mobilization? My concern is the onset of inflammation from doing the mobilization. Paul, do you want to answer it or?
Yeah, that's a good question. And I think one of the reasons that we include steroid in the injectate is because people do have that reactive inflammatory response without it. And so the studies that they just hydrodilated with saline and some anesthetic did not do as well as the patients that had saline anesthetic and some steroid in it. And so that's why we include it. And I tell patients that. I'm sure there will be some questions about the diabetic population and what are you differently in those patients. We may do a little less steroid in them, but overall, again, to kind of dovetail a little bit, the diabetic population does not seem to do quite as well with any of the procedures, whether it's arthroscopic capsular release or hydrodilation. So at least that's what the studies seem to bear out anyways. I don't think I have enough of an N yet to tell you that, but yeah, that I think that hopefully that answers that question.
Okay. Anamika, I think it's pronounced Anamika, maybe Corbett, asked, what is the typical frequency and duration with therapy following the procedure? I think we discussed that probably. Maybe that was, we didn't know you had that question there, Anamika, but
Sorry about that.
yeah, first day for sure, relatively hard and fairly aggressive, and then continuing. We don't necessarily do it every day, but I have seen some people that are a little stiffer and don't seem to stretch as much, that I will say to have them come in and see people for every day for a week or so. But a lot of times it's, a couple times, 2 to 3 times a week. And then of course we give them a good solid home program that they're doing on their own at home too. So Terry Black, I've had a patient tie, or my thing is my questions are moving here. I had a patient tie their arm overhead while sleeping to a bed frame. Wow, okay.
Hey,
That
that's
sounds-
old school. That
Yeah.
is old school.
That's old school, or that's something else, Phil, when you're tying your hand to the bed frame. Sorry, okay. That was too much, wasn't it?
Actually,
All right. Dan Prohaska, what phase of adhesive capsulitis do you feel hydrodilation works the best?
Yeah, this is a good question. I think that the answer that I'm going to use comes from somebody else, and I would say it would be more acute. I think the earlier we can get to them, the better. Because it just seems to kind of impede the freezing process. Is my hope for the answer on that one. I know that's a hard one, and it's one of the things that I would kind of like to study with this to see, all right, how long have you had that? And then how are we doing after we actually do this, and kind of compare the different phases.
How do they respond? Yeah. All right. Dan Cahill, shout out. Dan's from Wichita too. Have you ever been to the Catalina wine mixer? Is that a question for you, Paul, specifically?
Yeah,
I don't know the inside joke there.
there must be one.
Yeah, if
Gotta
you've
be
ever
one.
seen Step Brothers,
Oh, yeah.
I'm hoping to get invited someday.
All right. Terry said he's been practicing for 41 years, so he's seen a lot. Congrats, Terry, for practicing that long. That's awesome.
Yeah.
I'm about with
All
you,
right.
Terry.
All right. All right, let's get back to the actual article now here. Maybe we'll weed some of those questions out. We'll come back in just a little bit here. Paul, they talked about doing the injections both anterior and posterior. Do you do both anterior and posterior for the actual hydrodilation?
I've only done it posteriorly. And yeah, this is a question that I think is a really good question. Because there's at least one study, if not more, that they feel like doing an anterior approach going through the rotator interval seems to have a more improvement in range of motion deficit. And they think that the reason for that is that the anterior capsule seems to be a little more pliable than the posterior capsule with this process. And so because it maybe stretches out a little bit better in the anterior portion than the posterior, that maybe people actually do better with the range of motion deficit afterwards. I'm not accustomed to doing that, but I certainly don't think it would be that challenging. And so what I've actually told patients, the few that we've had that have not done better with this, I've told them, if we get you feeling better, but we don't get any range of motion improvement, which has happened with a few, that I would entertain doing it from an anterior approach the second time. So that's certainly on my mind and something that I have an N of 0 right now, but I'd like to try.
The second article actually talked about when they did their study, they actually did 3 different dilations, like 2 weeks apart. Is there any use for that, you think? I mean, doing it just like standardly doing it more than one time on everybody?
Yeah, I think the reason that they did that really was the hyaluronic acid, if I'm not mistaken. Which is a whole, another interesting subject, but I don't know. That's honestly my answer. I'm not sure, because I think the other thing that they did in that second study is the volume that they injected was much less than what we're doing. And actually, what I think what the first article, I think the average was probably about 30 cc's injected into the joint. And if I remember right, the second one was about 20 or less.
I didn't write it down, so
I
don't
can't
know.
remember what it was either. I think it was less than 20. So I just kind of wonder if volume wasn't maybe a bigger issue there and why they thought that. But I can't remember what hyaluronic acid they used either.
Yeah, I think, well, maybe I can get to it here when I get
I can find it.
Do you mind looking, Barb?
I'm
So,
getting there. Yeah.
Paul, was historically when they did, so they've done this forever. I mean, this isn't like a totally new procedure. I think the way you're doing it with the medicine and anti-inflammatories and steroid in there is maybe relatively new. Back in the old days, they just injected saline, right? And they just tried to stretch it. I mean, that was it, right? They didn't do like a bunch of other things in the injection. So
Yeah.
maybe that's why it didn't work as good then, and maybe the medicine is very helpful.
I did find it if you're interested. It's 2 mils of high molecular weight hyaluronic acid, something out of Seoul, South Korea. 4 mils of 2% lidocaine and 14 normal saline. So you were right, 20.
Okay.
You know that was about it.
Okay.
18, 19, 20.
Question from Victoria Gray. Would you use this on a patient with functional neurological disorders with tremors from adhesive capsulitis?
I'd probably try it.
I mean, it wouldn't.
I mean, if you know, it's kind of one of those, if we've had a hard time with everything else, and this is, especially if this is a last resort, I certainly think I would try it.
There wouldn't be a that's not a contraindication for it, is it, or anything?
Yeah, I think really I'm looking a lot at pain and range of motion, and if they have a range of motion deficit, I think it's reasonable.
Okay. An anonymous attendee asked, would a 45-year-old with DJD and degenerative labral tear with moderate decrease in ER and IR benefit from this procedure? So maybe a different population. That doesn't sound like a for sure frozen shoulder. I think you wouldn't do it just for someone with some general loss of motion, right, Paul? You'd want to make sure they had frozen shoulder for sure, right?
Yeah. I mean, I may just consider a steroid injection in them first and see how they did, and see if they have a range of motion improvement just with taking their pain away potentially. So yeah, I would consider it, but if it's, I try to tell what the range of motion deficit is from, is it's more from the DJD or the, tight capsule.
Yeah, or the labral issue they have.
Yeah.
Hey, Elania Newman. How'd you say?
Elena. Yeah.
Elena Newman. Hey, Dr. Cleland, delayed shout out back to my brother. There you go.
Yes.
She's on.
That's awesome.
Another question. Does insurance cover this procedure, Paul?
Part of it. So, this makes me chuckle because if Dr. Prohaska is still on here, we've kind of discussed this. So in a nutshell, yes. The procedure, what we'll bill for is typically an office visit, and then we'll bill for the joint injection, and we'll also bill for the nerve block. The nerve block is what's had a hard time getting approved, and it usually insurance, or oftentimes anyways, insurance will kick the nerve block back, and so it'll end up being like a write-off, but we won't have the patients pay for that out of pocket. We could get to a spot where we decide to do something different about that, but right now, no, everything that we're billing for is either covered by insurance or it's just getting written off.
Yep. Well, so we can get on to the next paper. I'll just tell you what the abstract said. From doing the meta-analysis, hydrodilation leads to at least transient, more marked improvements in shoulder disability and passive external compared to interarticular corticosteroid injections by themselves. Hydrodilation may be a preferable option over manipulation under anesthesia, given its lower cost and more better patient convenience. is what essentially kind of what the article ended up saying in the end. So, all right. Do you have any closing thoughts on it, Paul, before we go to the next one, which is the hydrodilation with hyaluronic acid? You want to just jump into the new one? Barb, you got something? What do you got? No. Who was
Answer
talking?
mine.
Was that you, Barb? I thought I heard someone
No.
asking. Okay. All right. So the second article, efficacy of combined ultrasound guided hydrodilation with hyaluronic acid and physical therapy in patients with adhesive capsulitis, a randomized controlled trial. So Paul, talk to us about adding hyaluronic acid for patients with adhesive capsulitis.
Yeah, I thought this was interesting. I really had not considered it much, and I still don't know that I am considering it, to be quite honest. But I think the idea is that they think hyaluronic acid, potentially inhibits kind of an inflammatory response, potentially from the hydrodilation, and patients do seem to, get some benefit with, the hyaluronic acid injection in arthritic joints, substance that seems to really not have a whole lot of, risks with it. And so I can see why they would want to do it. They separated this into 3 different injections, and they did 2 cc's of hyaluronic acid. There's obviously different formulations of hyaluronic acid that you can inject. And when, hyaluronic acid, I think, started, it really was what we call a series. So you would inject it, and then you would do injections again, either weekly, for 3 to 5 weeks, or you might do it monthly. It kind of depended on what you wanted to do. But the idea that you kind of do these in separate injections is something that I didn't really love, but that's what they studied. So I can see kind of why they did it all. The tough thing about this is that in the United States, hyaluronic acid really is only covered by insurance for knee injections for arthritis. And so getting this covered in the United States for shoulder injections is going to be darn near impossible, not to mention for adhesive capsulitis as opposed to arthritis. So this would be really difficult. And I think the way that we would potentially do this is have them go get hyaluronic acid from Turkey. It's kind of a joke, but Manske may know some of this. My partner does this quite a bit more than I do, but if their insurance isn't going to cover it, we'll give them a prescription and they'll obtain this through an online pharmacy, and it comes from Turkey. And then we'll inject it. And we've had good success with it when we're doing it in the knee joints, but I've never done it in a shoulder joint.
In the shoulder joint.
Yeah.
How much does it cost for that? I mean, so if you had to do it and they had to pay out of pocket, is it a huge amount?
It's not huge. It's a few $100. It's usually like $300. Yeah.
Okay.
Yeah.
What's Paul, they described in this study doing ultrasound guided versus anatomic injection. Is anatomic just you kind of guessing where it's at? What does that mean, anatomic versus ultrasound? I know what ultrasound guided is, but what's anatomic injections?
Landmark guided injections.
Okay.
Yeah, kind of doing it by feel, if you want to call it that.
Okay.
Yeah.
And then the other thing they did, I think in this study, didn't they inject it to a certain pressure? I mean, they actually measured the pressure that they injected it to. When you don't actually record the pressure, right? You just kind of do it by feel.
Yeah, I thought that was interesting. We just do it by feel. We don't measure the pressure. Yeah.
How would they measure that? How do you measure that? How would they measure that? Do you know?
Yeah, I mean, you can have like pressure measuring devices and see, like, if you're going to do a lumbar puncture, for example, the first thing you want to do when you do a lumbar puncture is you want to measure the opening pressure. So you kind of see, you attach a device to kind of the end of the needle, essentially, and you see how much the fluid goes up, and so you can measure the pressure. So I'm not sure if that's how they did it or not. I didn't catch that.
Yeah,
but
I thought they said they did measure the pressure. That's what I just wondered how they did that. So it's kind of standard. therapists, I guess, don't always know all the details of all the procedures that you guys use.
Yeah.
They
It's not
also
something
said,
I've ever seen. I don't think it's something I'm going to start doing unless I see some evidence that says we need to get to a certain pressure.
okay,
Yeah.
you mentioned doing injecting the corticosteroid in the joint with the just the standard way that you do that. And this article then said that using the hyaluronic acid may be better than injecting corticosteroids for people that are concerned about corticosteroid use. What is there's a question here from Mark Rosales. What are the possible contraindications with using the corticosteroid while you're injecting?
Yeah. So I think just to address the first part with the steroid versus hyaluronic acid, I mean, I think in a world where insurance has no problems covering the hyaluronic acid, I would certainly entertain doing
Fine to
it.
do it.
And I think that's really the main reason that we're going to do steroid pretty much every time. If a patient comes in and says, well, I've got hyaluronic acid, I bought it from Turkey, I want you to inject it in there, I'd say, okay, I think that's reasonable to try. Let's do it. As far as contraindications to both steroid and hyaluronic acid first mainly would be an allergy to eggs, and then you could use a different type of hyaluronic acid. Or if they've had an injection site reaction to the hyaluronic acid before. But otherwise, yeah, contraindications to steroid, I'd say probably the one we run into the most would be, diabetics where their blood sugar goes way high when we inject them. And in those people, I'll have a discussion about how high does it go? How long does it last at that high? Are we in danger of potentially sending you to the hospital, for development of like DKA or something like that? If I feel like the risk is low, then I'll do kind of a typical dose of steroid and see how they react to it. If I feel like the risk is really high, then I might decrease the dose, and then discuss with them that, hey, I think you probably are going to need to increase your insulin amount or make some adjustments. And I encourage them to reach out to their PCP about that, or whoever manages their diabetes. And usually they're fairly comfortable, especially if they're insulin dependent, on making adjustments with that. The other one is, if they have a history of avascular necrosis or other reactions to the steroid, I'm definitely careful with that. And that's somebody that I may choose not to do steroid in.
Yeah.
Yeah.
What does the Philip I don't how do you guys know how to pronounce Poget? Poget? Is it? I'm not sure how you pronounce Philip's name. Philip. I hope I'm saying Philip right. Felipe. How long does it take for the extra fluid in the joint to be absorbed?
Good question.
You have no idea.
Not sure. Yeah.
Okay.
I think that I don't know. I would say probably in the line of days to weeks. That'd be a question I'd honestly wonder what a surgeon would say to that, especially if I'd like to see if we failed on our hydrodilation, do they see any of that residual fluid in the joint? I've not done any repeats on anybody, and the reason I mention that is if I've got one that I've actually talked with Rob about doing a repeat, but in those people, I've looked at this one and the fluid's not still in there, so I would think it's days to weeks.
Okay. All right. Ashley Baker, I'd never heard of this treatment before this webinar. How widely is it being practiced? Are there just a few types of specialists who would typically do it? Sounds like a question for you.
Yeah. Yeah, I think it's growing. I think it's growing. I think you'll see more people do it. Our medical society called AMSSM, they're putting more information out there about this. And usually when that happens, a lot of the physicians that see these lectures and conferences and stuff, they'll start entertaining it. They'll start getting confidence to do it. And I think a lot of it is just based on need. I think with ortho group that's got a lot of ortho docs and they see a lot of it, I think those are going to be ones that you're going to see more of it. And like I said, prior to doing this in March, we just don't see as many frozen shoulder patients. And so I think it's going to be based on need and where you're at. I would bet if you're in a big city that there's somebody around that's probably doing it.
Which
I don't know.
kind of,
I say that with the caveat that Barb mentioned she's in Grand Rapids and doesn't know anybody doing
but
it.
one person already answered me back. A friend of mine already answered me back, so I already got somebody that I know who does it in Grand Rapids. So,
Okay.
but if there's any indication, like around the world, there were 39 studies in that meta-analysis. I mean, that surprised me actually that their inclusion, they were able to find 39 studies.
Yeah, 2,623 participants in those 39
So
studies.
it's not like nobody's doing it. Yeah.
Mm-hmm.
Yeah, I think it's done more than we realize, to be honest.
Yeah.
And really, and I'd heard doctors talk about it at different meetings, but until Paul started doing it, I hadn't seen patients that had it done, and always wondered how well it would work. Phil, let's get you talking tonight a little bit. Is your volume off? No, no, I knew you were. I knew you were messing with us. I knew you were messing with us. So Phil,
I've seen hydrodilation in the literature for the past probably 10, 15 years. It was popular in Europe. And in the region over there. And it's interesting that it's getting popular this way. I think though that the meta-analysis was not too great for me.
It wasn't.
In terms
tell us why. Tell us why, Phil.
Well, I mean that when you what you said, what did you say? 2000, what did you say?
Yeah, 2009.
The problem was that only 20 of those were actually randomized controlled trials out of the 39 that they used. And I don't know why they would call that a meta-analysis. When they did a meta-analysis on those studies, but it made it look like it was a bigger study, bigger thing than it really was. Then they went in and did some more of these, comparisons of the hydrodilation against anything, which they call this reference in the figures 8 through 10. It just wasn't your traditional meta-analysis in the fact that you just include randomized controlled trials. They did some good things. They did some okay things, but in general, the results are, it's not that big of a deal. When you look at the forest plots for the results, you basically had range of motion, internal external rotation at the side. Passive external rotation was the most statistically significant part of the whole thing. So I think it as if everything else, it's a bell-shaped curve. It's going to work great on some people. It's going to work poorly on some people. And in the middle, you'll get some that it does, some that it doesn't. So it's worth a shot.
Phil, on this second study, what do you think? I think we've maybe asked you this. I've asked you this before, but so the second study was supposed to be more of a randomized controlled trial, not a meta-analysis or a systematic review, a randomized controlled trial. But all their outcomes were pretty much mainly patient-reported outcome measures with just a few shoulder motions. How valuable is that to you when you have these studies where the outcomes are trying to find what they all are? They're the basically the shoulder patient-reported outcomes. It's not
right. But so they did measure range of motion, right? So, and the between group comparison was not significant. The thing we know now is that patient-reported outcomes are huge. They are part of this whole value-based care part of things, and there is the problem of subjectiveness to it. But if you look at things like a constant score that have actual range of motion and strength measurements, is the patient actually reporting it, or is the person who's taking that survey
information?
Yeah,
Mhm.
are they recording it? That's my first question. Usually it's just the patient. That's the easiest
Mhm.
thing to do, right? So I get it. But I'm looking at this and going like, well, what else is there to know? Range of motion. Yeah, that's what's most important. Pain, it's here.
Mhm. Mhm.
I mean, what else are we looking for outcomes for frozen shoulder besides range of motion and pain?
You could look at strength, but strength typically isn't as big
Mhm.
of an issue
Later.
as range of motion and pain is. Yeah, so it's really
Uh,
pain. I mean, it's pain and
Can I
function.
jump in on this one real
Sleep.
quick?
Yeah.
Sure.
My biggest
Of course.
chuckle on this one is what they did for therapy. So they did a tailored exercise program, Codman's, wall climbing, stretching maneuvers using a towel and bar, and 3 different modalities: shortwave diathermy, which none of us use around here, ultrasound diathermy, and interferential current. So a bunch of passive modalities. So, and I'm just gonna put my Phil hat on. Is there's no tidier here. There's nothing about what they did with these people. I got no clue with what they did on these people. So in terms of, they went to a 12-week study period, blah, blah, blah. They were supervised. They were supervised on a one-to-one basis. I don't know how much they did. To your point, Dr. Cleland, like how many times a day were they doing a home program? I mean, who knows? The detail on the interventions on the therapy side were C minus, in
Yeah.
my opinion.
This, I think that's a lot of studies, unless they're in like truly PT journals, a lot
Right,
of them are really
right.
minuscule on what rehab was done.
Hmm.
I agree. So injection with hyaluronic acid showed benefits in pain reduction and improvement in
Hmm.
passive range of motion of shoulder disability compared to PT alone. Found overall shoulder range of motion in all planes was improved in both groups. So it was improved also in the group that did the PT without the injections.
Hmm.
However, insignificant between the two groups. So
Right.
hydrodilation treatment was not necessarily better than just PT alone for the most
I
part.
always could caution people, do not look at studies that do A plus B versus A as being
Hmm.
saying that B is effective,
Hmm.
because it's just more treatment. And there was no placebo control here
There wasn't at all. You're
or
right.
an injection that was not hyaluronic acid. So I just, again, uh, these studies are nice to see in print and things like that. And remember that there's going to be publication bias, and a lot of these things they're going to try to find things that are positive for what they do. So as with everything else, bell-shaped curve. It works great sometimes, it doesn't work all the time.
So I guess my biggest question with the finding was, is it more important to have so is it more important to have pain reduction and a reduction in disability or range of motion? Or is range of motion more important than pain reduction and disability?
Well,
Is there any
that's
way to answer
where
that?
I go back to the patient-reported outcome measures. What's important is what they want. And so that's why I think I actually kind of like them just using PROMs for this. And it really does go back. I think it's projecting to where we're going in our future of value-based care, is that if the patient thinks that they have a good quality outcome, that's what the hospitals want. That's what the medical systems want, is they want patient satisfaction.
Hmm.
And if that means that they got better range of motion, better strength, that's great. Then they're happy, everyone's happy, then the value goes up.
Agree.
We have time for a couple questions, you guys think? We got like
Yeah.
5 minutes here.
Sure.
Daniel Zambini, how much improvement do you typically see with regard to motion and pain in these patients following the procedure at your follow-up at 4 weeks? Do you typically see improvements in pain more than motion, or motion more than pain at the 4-week follow-up?
Yeah, I think, and this kind of touches on what Phil was saying too. I think most patients have pain relief. I would say I see more of that than I see range of motion improvement, which is somewhat, I'd say a little bit, I'd like to see everybody have range of motion improvement. But, one of these things that I would kind of like to study, but is so subjective, is, are you happy with what we did? Just to
Hmm.
Phil's point, is like,
Yeah.
are
Yes or
you
no?
glad we did it? And I
Patient
would say,
satisfaction.
yeah, I would say almost everybody is happy with it. I've had, I think, less than a handful that have not really felt like they've been happy with it. So all that to say, I think those people, there's definitely people that feel like, hey, my pain's a lot better. My range of motion isn't much better, but my pain's better. And for that, I'm definitely happy I can
Better.
sleep now. Yeah. And they at least feel like, okay, I think my range of motion is going to come. And I think one of my mantras with this is if I can just get some pain relief with these people, they're usually happy. And if I can just maybe get the process to start, thawing out, if we can at least just get you going the other direction, I think we've done the right thing. So
Yeah, if you can move that needle just a little bit, maybe
Yeah.
we're gonna.
yeah.
And Paul, when you do these, I haven't been there when you've done them, but they're not sedated, right? They're wide awake and
Yeah.
fine. Yeah.
Yeah,
Right.
I
Someone asked
forgot
that
to
question.
tell. I usually numb up the skin with a little bit of Lido before doing any of it. So most people tolerate it really well. There's a few patients that they feel every bit of it, and those are not super pleasant, but that's not the norm.
Yeah.
Yeah.
All right. Well,
One thing
guys,
I was going to say,
oh, no, go ahead. Yeah.
I was going to touch on what Phil said about the meta-analysis. When I read it too, I was like, man, this is a little underwhelming for what I was kind of hoping to see. I was like, man, should I be doing this? I lose a little confidence in all this based on this meta-analysis. But so we'll have to see. And that's one of the reasons we're actually going to take what we're doing and study it and try to do an efficacy study, kind of see if what we're using is really working, and look at ranges of motion and patient satisfaction and pain outcomes, that kind of stuff.
But Dr. Cleland, I don't want to discourage you from this because I think that there's value.
No.
So tell me, anecdotally, what are you seeing overall if you did your own meta-analysis?
Yeah. I think so far, almost everybody is happy with what we've done. Some people have had really dramatic improvements, like Rob has said, where we'll do an injection. I did one yesterday morning, and this gentleman had immediate improvement in range of motion before we let him go out of the office. And he kind of looked at us and he was like, okay, you got my attention because now I can do this, and I couldn't do it 20 minutes ago. So some of them are really dramatic, and those are the ones that obviously make us really happy and want make us want to keep doing it. And I'd say the ones that don't have improvements in range of motion are more discouraging, but they still usually have pain relief. I think if I'm going to give a percentage, anecdotally, I would say 70 to 80% have improvements in range of motion. And I would say probably 50% of them are happy to the point where they feel like they're pretty much back to normal. And I definitely think the other 50% are not back to normal, and there's probably half of those that don't really feel like they had much improvement in the range of motion at all.
So that's why I'll end my points here with randomized controlled trials are not what we should be basing our clinical practice on solely, and that these types of significance of the p-values of this garbage is not clinically relevant, in my opinion, and that what we would need to be doing is big data. We need more pragmatic stuff like you're doing into a database to find out what's actually happening, because these randomized controlled trials are not always practical. They're very sterile. They control for too much. And what you're seeing every day, that tells me a lot that there is probably something to it.
Yeah.
Awesome, Phil.
That's
Thanks.
the people that did this before me that had this huge N and had huge success. I'm like, man, why aren't you guys putting that data out there?
Why aren't you publishing it?
Yeah, because they seem to have great, experience with it. And I'm like, man, I don't know why that data is not out there, but I wish it was.
All right. Hey guys, we're past our time. The hour flew.
Sorry.
Always
That's it.
does.
No, it's not your fault. Appreciate it. We appreciate you being
Good.
on, Paul. Everybody that's listening, we got a fantastic 2025 planned already. We're trying to we got Dr.
Yeah.
Preventure already lined up. I think we're gonna have JT Tokish. I think we're gonna have Seth Sherman. We have Rachel Frank. So we've got like these great orthopedic surgeons that's gonna be on in next year, 2025. So watch out for all those times. And we're gonna have Dr. Prohaska back probably a couple times over 2025. So
And we still have one more in 2024,
one more in
December
2024,
11th.
December. Yep.
Number
So that
11,
last
yep.
email will be going out soon. So thanks everyone that stuck around to the very end. I did notice a couple people connected by phone. I can't the system won't send certificates to a phone number. So if you don't get your certificate and you were connected by phone, email me and I will send it to you directly. So with that, we will see you in December. Have a great
Thanks,
Thanksgiving.
everybody.
Bye,
Thanks,
everybody.
Paul.
See ya.
Yeah.
Thanks again,
Thank
Dr.
you,
Cleland.
guys.
That's great. Thank you.
Yeah.